PA at MSU Sports Medicine. He's also been the PA for the MSU field hockey team and Lansing Lugnuts. He's currently the director for the athletic training residency program at MSU Sports Medicine. Again, we'd like to thank Mike Strauss for all of his support in sponsoring our athletic training lecture series. Tonight, we have two amazing speakers that will speak on psychological rehabilitation and mental health for student athletes. Each speaker will present for about 40 to 45 minutes and then answer questions for about 5 to 10 minutes. If you have questions throughout the presentation, please type them into the question and answer on the webinar. Our first speaker tonight is Dr. Shelby Bias. Dr. Bias is a certified athletic trainer with an expertise in psychology of injury. She completed her Bachelor's of Arts degree in athletic training at the University of North Carolina, Chapel Hill, and her Master's of Science and PhD in kinesiology at the University of Kentucky. She's currently an assistant professor in the Department of Kinesiology at MSU. Dr. Bias has over 20 research publications and was recently granted a $750,000 NIHK award. Her research examines the impact of psychological responses on clinical outcomes after traumatic knee injury in the high-functioning, physically active population. Please welcome Dr. Shelby Bias.
Thank you so much for that introduction, Dr. Basson. I'm going to go ahead and share my screen here, and then we'll get rocking and rolling. As Dr. Basson mentioned, my name is Shelby Bias, and I'm an assistant professor in the Department of Kinesiology and the director of the Behavioral Research and Athletic Injury Neuroscience Lab, or the BRAIN Lab, part of our athletic injury and rehabilitation labs here in the Department of Kinesiology. I'm excited as I get to talk to you all about psychological rehabilitation for injured student athletes. So I have no conflicts of interest to disclose. By the time we finish this lecture, I hope you all will have learned a few different things. So I want you to be able to discuss signs and symptoms of maladaptive psychological response to injury. I want you to be able to identify different psychological interventions that can be used to decrease injury-related fear and improve confidence after injury. And then I want you to be able to explain this concept of psychologically informed clinical practice. Now, as we go through this lecture, before we start talking about any of the nitty-gritty details, I want you just to take a second and reflect to think about some of the most challenging patients you've encountered in your clinic. Do we have adherence issues with these patients? Are we having some return to sport difficulties? Do we see increased levels of fear, decreased confidence, or potentially an inability to manage pain? And while tonight's lecture, we're going to focus more on fear and confidence, a lot of the psychological interventions we discuss can be applied to address many of these issues discussed tonight. So keep in mind these patients, and as we progress, I hope you can identify something that can help them moving forward. The International Classification of Functioning, Disability, and Health, or the ICF model, is our governing model from a rehabilitation standpoint to help to guide our clinical practice. And what the model suggests is that when we have a health condition, we can address body functions and structures, activity limitations, and participation limitations. Now, environmental and personal factors will influence how activity and participation limitations and bodily functions and structures repair. Now, let's say we have someone who has an ACL injury, and a lot of the examples I'll discuss tonight is related around ACL reconstruction, as that's my area of expertise. Let's say we have someone who has this ACL injury. We can have surgical intervention to address the integrity of the knee joint. We can put the patient through structure rehabilitation in order to get them back to running and cutting and jumping. However, what we're seeing is that these patients simply aren't returning back to sport. We see that these patients are at risk of having a secondary injury. And potentially what we are seeing is a failure to address environmental and personal factors that could potentially be influencing these outcomes. So when I say personal factors, one thing to keep in mind is psychosocial factors. So this concept of psychologically informed clinical practice is simply incorporating the patient's beliefs, attitudes, and emotional responses into the patient management based on biopsychosocial models. Now, we're not saying that a psychologist become a rehabilitation specialist or a rehabilitation specialist should become a psychologist. It's simply saying that we should have a balance between the traditional musculoskeletal rehabilitation that we engage in while incorporating cognitive behavioral and psychoeducation interventions. So we're looking at this balance between each of these tiers of rehabilitation. So biopsychosocial. What do I mean when I say that particular term? And how do we take a biopsychosocial approach to rehabilitation? So let's break down the word. So first, from a biological perspective, we're thinking about what are the strength deficits? What are our functional deficits? Range of motion, and some of the things that we assess on the day-to-day in our rehabilitation. Now, psychological factors can influence the biological, and biological can influence the psychological. So psychological factors can be things like increased fear, decreased confidence, failure to adhere to rehabilitation. And then lastly, the social piece to it. So we're thinking about social support. How is the patient's interaction with their family, with their coaches, with their teammates? Each of these three tiers can influence how a patient recovers after their injury. And as we're working with these patients, our goal is to try to be right there in the middle. Can we identify, assess, and consider how psychological and social factors are also influencing the biological side? So the Merriam-Webster definition of biopsychosocial means of relating to or concerned with biological, psychological, and social aspects, in contrast to strictly the biomedical aspects of the disease. So we're taking a step further and not just focusing on the biological, but the other things that can influence outcomes as well. So what are some common psychological responses to athletic injury? And as you can see, there's a list here. There's a ton of different ones that we could see. We can see a depression and frustration after someone has an athletic injury. We can see some catastrophizing behaviors or malingering. Specifically today, I'm going to discuss how injury-related fear and decreased self-efficacy or decreased confidence can be present after injury and how they can influence outcomes. Now, one thing I always do like to mention when we talk about psychosocial responses is that we may not always see a bad response psychosocial. We may see the patient experience some relief. The injury may give them some time to reflect on themselves, be able to explore other interests. So you may also see patients on the other end of the spectrum too. But for tonight, we're going to focus on fear and self-efficacy / confidence. Now, are we really seeing poor outcomes in patients who have these psychosocial responses? And simply put, there's tons of literature that is coming out consistently suggesting that these psychological responses are influencing return to sport, physical activity, self-reported function, secondary injury risk. And I'll talk a little bit more about one of the papers that I completed that looked at return to sport and physical activity. So in this particular paper, we wanted to start to conceptualize an approach of this patient, evaluation and assessment from a biopsychosocial perspective. So we had ACL patients come into the lab and complete a series of functional outcomes. So we tested their strength, we looked at limb symmetry with hop testing, and then we looked at jump landing biomechanics using the landing error scoring system. And then we had them complete a series of patient-reported outcomes, including the Tampa Scale Kinesiophobia, which measures injury-related fear, knee self-efficacy, which measures self-efficacy or confidence, and then the knee injury and osteoarthritis outcome score, or the KOOS, which measures self-reported knee function. And we wanted to see whether a combination of these functional and patient-reported outcomes could be predictive of returning to sport, as measured by the Tegner Physical Activity Assessment, and then physical activity as measured by a week average of average daily step counts measured by a pedometer. Now, what we saw was interesting is that none of our functional outcomes actually went into our models when we were assessing what was predictive of these outcomes. So don't worry about the nitty-gritty details on here as it relates to the percentages. The take-home point from this is that as it relates to return to sport, patients who had increased fear were less likely to return to sport. And those patients who had decreased confidence and worse knee-related quality of life demonstrated worse or less physical activity compared to those patients with increased confidence. And this is concerning. As we think about the impetus of this particular surgical procedure, is to allow patients to safely return back to sport and engage in lifelong levels of physical activity. But we simply see that it's not happening. One theoretical model that can help us to understand potentially why this is occurring is the fear avoidance model. What the fear avoidance model suggests is that when you're injured, you have this painful experience. And during this painful experience, you can go into one or two different pathways. You could have low levels of fear. You can confront your recovery and your injury experience, and then have a normal recovery. Now, a patient can also go into this other pathway on the left-hand side. They can start to engage in catastrophizing behaviors. So they may start to magnifying their pain or magnifying the risk of re-injury, or feel helpless, like they can't do anything to address their pain. This can then lead to fear of pain or fear of re-injury, pain-related anxiety, which can then present as avoidance behaviors. So the patient's going to avoid the things that cause their painful experience and have caused this fear, which then leads to a cycle of disuse, disability, and depression. So some of my work has started to explore, okay, are we able to objectively quantify how fear is presented in this patient population? Are there other signs that we could potentially look at to see how fear and confidence are presenting? So we completed two different studies. One study, we wanted to look at, is there a relationship between injury-related fear and reaction time? So we had a series of ACL patients come into the lab. They completed this lower extremity reaction time task, where they were instructed to deactivate the lights as quickly as they could with both their injured and non-injured limb. And all of these patients were about 1 year post-ACL reconstruction. And then we had them complete a series of self-report measures that measured fear. And what we saw was that patients who had increased levels of fear had slower reaction time. And literature suggests that slower reaction times associated with secondary injury risk. So as we're working our way through that fear avoidance model, potentially we're seeing some delays in how in cognition or influences of cognition related to fear that may be presented from a neurocognitive perspective. Another thing we did was to start to see how was fear actually presenting in this population was to put patients who had history of ACL reconstruction and then healthy matched controls into a functional MRI to look at if brain changes were present. So on the top row here, we have our healthy matched control activation. And on the bottom row here, we have our ACL group activation. Red means increased activation and blue means decreased activation. I don't want to get bogged down too much in the brain stuff tonight because that's not the purpose of today's lecture. But take home point from this is that patients after ACL reconstruction activated emotional regulation areas in more depth while completing a picture imagination task of just sport-specific images and activities of daily living when compared to a healthy control group. So if just imagining themselves playing sports leads to differences in brain activation, imagine what's happening from a neurological perspective once they're actually back on the field. So this gives us further evidence that we need to potentially have this shift to psychologically informed clinical practice. And fear isn't just this subjective factor that's influencing these patients, but we're actually starting to be able to objectively measure fear in this patient population. Now, what are some other signs and symptoms, and what should we look for patients who may have fear and decreased confidence? From a physical side, we may see the patient exhibit increased muscle tension, some shallow breathing, a slow pace in rehabilitation. So we're thinking about turning on that fight or flight response. So we see something that is fearful. And then our body's going to respond to what we think is fearful. From a cognitive and an emotional standpoint, we may see excessive negative thoughts. So the patient may be overly self-evaluated. We may see that the patient's expressing negative emotions. And there may be some unrealistic expectations for these patients who have increased levels of fear. Socially, we may see patients start to withdraw from their teammates, even from the rehab environment. They may not be as communicative as they were previously. And then from a performance standpoint, we may see a decline in motivation and enjoyment. And we also may see just failure to progress throughout the rehabilitation. So that performance and rehabilitation may also be hindered. So we have all of these different constructs, and we talked a lot about what is fear, how is fear presenting, how is it affecting outcomes? So what do we do about it? Or can we even do anything about this? And the short answer is yes. So the integrative model of psychological response to sport injury suggests that we can potentially influence these emotional and behavioral responses. Now, what the model depicts is we see personal factors such as history of injury, personality traits, age and gender, and then situational factors such as social support, the sports medicine team. All of these are going to affect the patient's cognitive appraisal. So how they're viewing their situation. Do they feel like they have the capabilities and resources to overcome the physical and psychological demands of the situation? Now, we may not be able to influence personal and situational factors. Some of these things are just non-modifiable. But we can start to modify emotional responses as well as behavioral responses through the use of psychological skills. Now, the first thing we have to do before we actually intervene is to measure these emotional responses in clinical practice. So I'm not going to talk a ton about what these questionnaires are and what they measure, but just could a take-home point from some of these. So we have many dimension-specific patient-reported outcomes that measure psychological response to injury. There's some general ones that measure things like fear avoidance beliefs, kinesiophobia, or fear of movement or re-injury. We have a knee self-efficacy scale that can measure confidence. And then there's even injury-specific psychological questionnaires like the anterior cruciate ligament return to sport after injury scale, or the ACL-RSI. Now, there are cutoff scores developed for each of these questionnaires. I always encourage clinicians to not use cutoff scores to be the driving force for treatment decisions as it relates to psychosocial impairments. So let's say the cutoff score for the TSK-11 is a 17. So patients who score 17 or higher exhibit increased levels of fear. Now, my question to clinicians is, and other researchers too, is what happens to that patient who scores a 16? Do they not get psychological treatment? Simply, the best way to use these questionnaires in clinical practice is to look at them from an item perspective. See where the patient ranked or scored high fear or decreased confidence, and then talk with your patient about it. Secondly, the scores can be useful, but they're better at looking at responsiveness and change over time. So are the interventions that we're implementing, are they actually beneficial? Are they actually improving the patient's confidence? Are they decreasing the fear? So using patient-reported outcomes is great from a one, let's have a conversation with the patient, and then two, are we actually seeing change over time? So interventions. So one of the questions that I often get is, can athletic trainers, can rehabilitation specialists actually do this? Can we intervene? So we completed a review to look to see if rehabilitation specialists are effective in implementing cognitive behavioral and psychoeducation techniques. And there are certain techniques that rehabilitation specialists can do and can effectively do. And a lot of the techniques and all the techniques I'm going to discuss tonight are within the domains of athletic training clinical practice. So when I say cognitive behavioral therapy, what exactly do I mean there? One, if we can potentially affect how someone's thinking, so again, tying back to that cognitive appraisal piece, then we could potentially change how they feel about a situation. So again, those emotional responses. And if we can change those emotional responses, can we potentially address behavioral outcomes? And then as you can see this image, it's a cyclic relationship. Behavior reflects thoughts and thoughts affect feelings. So tonight we're going to discuss some ways that we can do that. One saying that one of my mentors has drilled into my head from a clinical perspective is perception is reality. So what the patient perceives as their reality is their reality. So we have to be respectful of that. So as rehabilitation specialists, as we may not think that something is fearful, but the patient perceives that. So we have to be respectful of that. And our goal is to try and alter their perception so we can alter that reality. So psychologically informed clinical practice. As I mentioned, there's a ton of different types of psychological factors. And as we're working through the different types of treatments, there are a couple different types of treatment targets that we can address with hopes of improving clinical endpoints, such as decreasing pain, disability, physical function, improving return to sport, and improving physical activity engagement. So different treatment targets. So we can have relaxation therapies, such as diaphragmatic breathing and progressive relaxation. Behavioral techniques, such as goal setting and graded exposure, which we'll touch on. And different types of cognitive restructuring techniques, including thought stopping and problem solving techniques that can all be integrated that are within the scope of athletic training clinical practice. And as tonight, we only have about 40 minutes, 45 minutes to talk through. It's just going to be a brief overview. Before we intervene, and as I mentioned before, communicating with our patients is an important piece to the puzzle. So I want to present a method that can help us to have these conversations about integrating a psychological intervention into clinical practice. Now, implementing a psychological intervention is a type of behavior change. And motivational interviewing is a type of communication strategy that's designed to help resolve some of that ambivalence about a behavior change. It's like a collaborative, person-centered guiding form to guide and elicit strengthen for motivation to change. And it can build trust and rapport with the patients and target motivation as the mediative factor. So even if from an adherence standpoint, this is also a great technique if you have a patient who's just struggling to come to rehabilitation. Motivational interviewing is a great route to start. So what does this look like? So we have 4 principles that we often discuss as it relates to motivational interviewing. The first one is expression of empathy. So when you're talking with your patient, you want to be empathetic. This can convey understanding in a non-judgmental way. Key thing here is to make sure you're being genuine when you have this conversation with your patients. Recognition of discrepancies. So as you're talking with your patient about potentially integrating this psychological intervention, identify the differences between current and future states that the patient may express. So if the patient says, yeah, I really wish, I know I have fear right now, but I really wish I didn't. Highlight that. So, okay, tell me more. So you have fear, but you wish you didn't have fear about this. Let's talk about this. So recognize those discrepancies when you're talking with your patient. Roll with resistance. So making sure that we're supporting and respecting the patient's autonomy. So from a motivation standpoint, allowing that patient to feel autonomous can help to increase motivation. Now, if let's say you recommend the patient try some type of psychological intervention and they're hesitant, roll with the resistance. Don't necessarily try and convince the patient otherwise. Listen to what the patient has to say, and then potentially reflect back there at a different time. And then lastly, support that patient's self-efficacy or their confidence. So enhance and affirm self-confidence and making sure you identify the client's strengths. So when they come to rehabilitation, do they work hard every single time? So make sure you affirm that and enhance that with that patient. So what are some of the tangible skills that we can do to implement these 4 principles into clinical practice. And if you remember a boat and what helps to move our boat, oars, you'll remember how to tangibly implement motivational interviewing into clinical practice. So what I mean by this, when you're talking with your patients, open-ended questions are always going to be the best route to go. Avoid yes or no questions and short answer questions. And often a concern is the patient going to talk too much? I don't have enough time. I don't have a lot of time. And athletic training facilities are crazy. But often patients talk for about 40 seconds if you ask them an open-ended question. And you get way more information from that open-ended question than you get from a yes or no question. Secondly, affirmations. So making sure you affirm your patient with genuine affirmations. So identify and comment on positive behaviors, comments made by the individual that speaks to the quality of their character and commitment to health. I see when you come into rehabilitation, you always work really hard. You always show up on time. And I know we have some patients that we struggle to work with, but you can always find something to affirm with that patient. R, reflections. So when you're having that conversation with your patient, genuinely be interested in what they're saying. Be curious about it and respectful. And this can convey empathy. Now, a reflection could be as simple as, I went to the beach this weekend. You as the clinician can say, oh, you went to the beach this weekend. Tell me more. That little bit of reflection can convey empathy and build that rapport with the patient to potentially convince them to engage in these psychological interventions. And then lastly, S, so summary. Bring together what the person has been saying, and as well as encourage the patient to summarize what you all have been saying. So this can tie it all together and potentially relieve some of that ambivalence for engaging in psychological intervention. So remember your ORs, so open-ended questions, affirmations, reflections, and summary. And there's some traps to avoid when we're thinking about implementing motivational interviewing into clinical practice. We are the experts, so it's easy for us to fall into that expert trap. Again, the goal here is to be collaborative, so work with your patient. And along those lines is try to avoid advice without permission. It simply is as easy as saying, would you mind if I shared with you my thoughts? This supports the patient's autonomy, and it can also make that relationship, again, collaborative instead of hierarchical. And then you also want to try and prevent from doing most of the talking, because the patient's own words are going to have the greatest impact on behavior change. Oftentimes we want to go and tell them all the things we want to know, especially as it relates to how great these interventions can be. But ultimately, you want to try and help guide the patient and then say, hey, is it okay if I share with you my thoughts? So if there's one thing you can remember from this section of this talk is talk less and listen more. Your patients are often telling you what they need if you just take a step back and listen to them. All right, so now we finally got to the part where we're going to talk about what do we do. We've convinced our patients and we've encouraged them and they're on board to engage in some type of psychological intervention. Where do we start? So as I mentioned, as we're thinking about the signs and symptoms of fear, some of the things we talked about were like muscle tension, right? And physiological responses. So relaxation training is a great route to implement because it can, one, relax the muscles. It can provide a mental break. It can renew energy and distract the patient from certain stimuli. So let's say you have a post-surgical patient and you're working on that range of motion and it's really painful. Potentially implementing a relaxation technique such as diaphragmatic breathing or belly breathing can help to distract that patient from the pain. What I often tell, especially athletic trainers, is that we do relaxation training all the time in clinical practice. We just don't actually name it. So when a patient goes down on a field or an athlete goes down on the field and they're hyperventilating, what's the first thing that we do? We calm their breathing, right? So breathe in through your nose and out through your mouth. Now, the goal of this is just to integrate that into other aspects of the rehabilitation process. So potentially before the athlete has to do a task that they're fearful of, have them take a deep breath in and then out. So with diaphragmatic breathing, the goal of it is to do belly breathing. So if you were to put one hand on your chest and then one hand on your belly, the goal would be to take a deep breath in through your nose and move that belly outwards and keeping that the hand on your chest stable. Now, there's a ton of different counts that you can use that you can work through your patient with. There's 4 counts, there's many out there. Just one that I recommend is encouraging the patient to breathe in through their nose for a count of 4, hold for a count of 4, and then exhale for a count of 4. Now, it usually takes about 2 minutes for the patient to actually start to feel some of the benefits of the relaxation. So depending on when you're implementing it, that's just something to consider. Now, let's say we have a patient who has increased muscle tension. Progressive deep muscle relaxation is a targeted way that we can help to relieve some tense muscles. So what it suggests is that it has this assumption that you can't be tense and relaxed at the same time. So if you purposely tense a muscle group and then relax, you can heighten that relaxation in that area. So while you're at home, just appease me for a second. I'm just gonna guess and hope that you guys are doing this with me. So just do me a favor, squeeze your hands as hard as you can for like 5 seconds. 2, 3, 4, 5, and then relax your hands. And you can feel that tension, that difference between that tense state versus the relaxed state. Now you pair the diaphragmatic breathing when you're implementing this deep muscle relaxation, and these 2 interventions combined are really great for relaxation training. Now, I'm not remiss to think that we don't necessarily have time sometimes to be able to implement these interventions within clinical practice. So there are a ton of tech-driven solutions that are available for us to be able to implement relaxation training into clinical practice. So Headspace and Calm are 2 paid apps that can implement mindfulness and relaxation training. And I'm not sponsored or anything by any of these. These are just generally from my own clinical practice, what I have used. Now, one app that's really great is Virtual Hope Box. And Virtual Hope Box is a free app. It's designed for patients who want to engage in relaxation training. So there's a whole Relax Me app on here that you can encourage the patient to download, and will guide them through that inhale, hold, and exhale process. There's guided meditations, there's deep breathing, and is a great application if you're looking for something to implement relaxation training on a busy schedule. All right, so we have our patients relaxed. So we're potentially adjusting some of the physical responses of fear and anxiety. Now, how can we start to address some of these more cognitive and emotional sides of fear and decreased confidence? One of the best ways to improve confidence is goal setting. And very similar to, as I mentioned, with relaxation training, we do a lot of these interventions already in clinical practice, but all I'm just going to suggest is a slight modification to how we do it. So goal setting. There are 3 different types of goals that we primarily can set. We can set outcome goals that focus on the outcome of an event, performance goals that focus on specific performance or functional task, and then process goals that focus on specific behaviors during the completion of the performance or functional task. So an example of an outcome goal would be return to sport. An example of a performance goal would be gaining full knee extension. And then a process goal would be keeping proper form while completing a sideline hip abduction. Now, outcome goals are really hard to control. Sometimes they're going to be things that are out of our control. A common outcome goal, of course, is return to sport, or I'm going to get my position back after I return back from injury. Sometimes there's someone simply that's just better than the patient who comes in after the fact. That is out of our control. Now, Successful performance of performance goals and process goals increases the likelihood of achieving an outcome goal. And from a confidence standpoint, when you have these patients achieve these smaller goals, it makes them feel good. And when you feel good, you're going to be more likely to achieve more goals. So we see more accomplishment. And as the patient's accomplishing these goals, they're feeling more confident as they go through the process. So again, from a more likely of achieving outcomes of returning to sport, we see successful performance of these performance and process goals. And then again, from a confidence standpoint, start with the smaller goals and then work your way up. So I'm sure most of us have heard of SMART goals, but just to reiterate, when you're developing your goals with your patients, whether it's an outcome, a process, or a performance goal, you want to make sure they're SMART. So specific, measurable. I often say the term action-oriented as well as attainable. So you want them to actually have to do something to achieve that goal. You want it to be realistic and then timely. And as you're working with your patient to develop these goals, actually write them down and create a contact with the patient. There's been some research that suggests that actually having the patient write down their goals is more effective than if you as a clinician were to write down their goals themselves. Now, don't just make the goals and then just put it in a filing cabinet and never look at it again. So making sure you actually monitor the progress. Are we actually achieving those goals? And show the patient the progress that they're making. And if possible, can you start to find a connection between some of their sports goals once they go back to sport and rehabilitation goals to combine both of those tiers? Now, again, as I mentioned, from a cognitive standpoint with fear and decreased confidence, we may start to hear or start to see the patient express negative thoughts. So we want to encourage the patient to start to balance their thinking and potentially engage in thought-stopping behavior, because positive thoughts lead us to feeling good. So the patient would feel less fearful, more confident. And the negative thoughts can lead us to feeling bad, so more fearful and less confident. So as we're working with our patient, if we hear them say a negative thought, says, I'm never going to get better, encourage them to think of a positive thought. I can and I will get better. Now, the caveat to this is don't create the patient's positive thoughts for them. Again, the patient's own words are going to be more effective than if you were to tell them. Help to guide them to identify what's something else we can say instead of I'm never going to get better. Is more meaningful when the patient says it versus when you say it. And then lastly, from an intervention standpoint, a combination that addresses both confidence and fear is exposure therapy. So we often hear exposure therapy from I'm going to address fear of heights or fear of snakes or spiders. But exposure therapy can be used to address fear in rehabilitation. Now, the key to this is a gradual exposure. So you want to work with your patient to identify hierarchy of fearful situations that may occur throughout rehabilitation, such as pivoting or running or jumping. And very similar to goal setting, you want to start with the least fearful task first. So when they are exposed to that task, they feel a bit more confident to progress to something that they may be more fearful of once they accomplish the least fearful task. So what could this look like in clinical practice? What's great is from a rehabilitation standpoint, we're already doing this in rehab. We're already progressing these patients in an effective way based off pain and soreness. But instead of just using pain and soreness, braided exposure suggests that you can integrate fear as a progressive mechanism. So let's say we have a patient who's afraid of completing a single leg forward hop. We can have them start with the double leg vertical hop, then assess their fear levels. If their fear levels decrease, then we have them progress to a double leg forward hop. Again, then assess their fear levels, progress them to a single leg vertical hop. Again, if fear decreases, then progress them to that single leg forward hop. Now, we've completed some work in this area to see if exposure therapy can decrease fear. And based off of the pilot study that we've run so far, graded exposure can lead to specific decreases in specific functional tasks. So on here is just an example of one participant that we had complete the study. And just to orient it to the figure, 0 means no fear. Higher scores on here represent higher levels of fear. The items in the red box are the 3 items that we addressed over a 5-week exposure therapy. So the patient here was afraid of landing after a jump, lateral lunging, and pivoting. So over the course of the 5 weeks, we addressed each of these functional tasks. Blue here blocks here mean the pre-test fear scores, and the green blocks here mean the post-test fear scores. So if you look at our red blocks, we can see a significant clinically meaningful difference between the pre-test and the post-test for those specific functional tasks, suggesting that it may be an effective intervention to address fear moving forward. Now, control the controllables. So like perception is reality is one of my favorite sayings. Control the controllable is one of my others. And my mentors have drilled that into my head over the years. So know what you know and know what you don't know. If you don't feel confident in implementing some of these things, it's always important to be conservative and make sure you refer the patient to an appropriate person. So I know we have a second half of this lecture that's discussing this, so I'm not going to hone in on this a ton, but making sure that we do our due diligence in referring with appropriate timelines, and then making sure we know the differences between mental health professionals and know who to refer to. So let's say you have to do this referral. What are some things that we should potentially have in this referral script? Making sure you're empathetic. Again, motivational interviewing techniques still here. In establishing rapport with that patient, gathering information in a non-accusatory way, and being sensitive to that athlete's perceived reality. So let's say I want to formulate this script. I described observed behaviors using I statements. So I noticed X, Y, and Z. Don't approach a patient and say, you are doing X, Y, and Z. So I've noticed X, Y, and Z. Seek clarification. Can you tell me more about X, Y, and Z? Always access the athlete's coping and support resources. So how have you been handling X, Y, and Z? Making sure you explain your competencies. There are things that are out of the scope of what we can do, and making sure that that patient knows that you're not helping them because you don't want to, or that you feel like they're not able to be helped, but simply is out of the scope of what we can do, and then suggest and recommend that referral. So now, how can you use these techniques to assist your patient? So thinking back to that first patient that I mentioned earlier on, is there a way that you potentially help these patients before they get injured? Or can we integrate some of these techniques into clinical practice that way? How can you help that particular patient who has been challenging throughout rehabilitation, throughout the rehab process? And then thinking about how can we maintain these psychological interventions as they return back to sport? So some final thoughts here. Again, the first one, perception is reality. So we have to be respectful of the patient's reality. And our goal with these interventions is to try and change their perception so we can adjust the reality. Be patient. These techniques take time and practice, not only for you to implement them, but for the patient to get them. The first time they try some relaxation, their training is going to be challenging. But the more and more you do it, the easier it gets, because your brain is a muscle. And just like you go into the gym to train your biceps, you have to train your brain too. Relaxation techniques and the behavioral techniques I discussed today are just a few of many psychoeducation techniques that are within the scope of our clinical practice to address issues after musculoskeletal rehabilitation. And then when in doubt, always be conservative. And then I always like to end my presentations with this fun little brain on a treadmill and say, don't be afraid to train the brain. Because if you're not afraid to train the brain, then your patients may be less afraid to go back to sport and more likely to engage in lifelong levels of physical activity. And I'm happy to answer any questions that you all may have.
I'd like to thank Dr. Bias for an excellent presentation. We have a few questions in the question and answer area. If you also have questions right now, please type them in. Dr. Bias, is visualization an activity that can be used before an athlete is close to doing it, or is it in terms of rehab could it be detrimental?
So visualization is actually, so imagery, I didn't actually talk about that today, but imagery can be a really good tool to use before someone's actually able to go back to do the physical functional task. So there is this concept called PET-LET imagery. And what PET-LET imagery suggests is that you can actually mimic activation in the brain from that's similar to if you were actually completing that functional task. So let's say you have a patient who physically can't complete a squat at this time because of functional limitations. Imagining themselves completing that squat can actually trigger areas of the brain that are similar if they were completing that squat in person. So it's actually a beneficial tool, and imagery can be really beneficial. And there's not a ton of detriment except if you imagine negative images. So you want to keep the imagery positive. So negative images can be actually detrimental. That's probably the only thing that I would suggest there.
Okay, and I have a question in terms of cognitive behavioral therapy. So we know that you are a certified sports psychology consultant that you can also talk briefly about. But one of my students would like to know, is cognitive behavioral therapy and psychoeducation, do these skills fall within our scope of athletic training practice or just reserved for psychological specialists like yourself?
So there are aspects of cognitive behavioral therapy that can be implemented by rehabilitation specialists. I often lean more towards the psychoeducation, which is definitely within the scope of what we do. So the relaxation training that I mentioned previously, the goal setting, the exposure therapy, some of these things can transcend into cognitive behavioral therapy. But from a true traditional cognitive behavioral therapy standpoint, I often leave that to psychologists and psychiatrists to implement.
Okay. Another question is from Alex Daly, one of our former athletic training students here at Michigan State University. And he says, Dr. Bias, excellent job with this talk, which I also second. Would a recommendation for clinicians involving tracking fear and other psychological signs and symptoms, so anxiety, fear of re-injury, over the span of the rehabilitation process? And how would you go about writing out an outline for a rehabilitation process affecting psychological signs and symptoms?
So that's a great question. Let me just break it down. So would a recommendation for clinicians involve tracking fear and other psychological symptoms over the span of rehab? So yes. So I would recommend using those patient-reported outcomes as potentially one of those baseline measures. So when you do your strength testing or you measure some type of self-reported function, throw in one of those fear questionnaires or those confidence questionnaires, and then assess that over the course of rehabilitation. As I mentioned, we want to try and address things from a biopsychosocial perspective. So not just only assessing the biological landmarks, so assessing their strength and range of motion at these major time points, also assess the psychological and the social landmarks too. And the second half of the question, how would writing out an outline of the rehabilitation process affect psychological signs or symptoms? So if I'm getting this correctly, is if you work with your patient, identifying those major time points and talking with the time points with your patient. Dr. Kavasan, do you think, am I interpreting that the right way?
I believe so.
So from a psychological side, I think it's important because when you're working with your patients, and from my own sports psychology clinical work, a lot of times these patients often don't know what to expect. And then the unexpected can lead to increased anxiety, increased fear, because we don't necessarily know what we're in for. So working with that patient to outline what the rehabilitation process would look like is important because it can give them some transparency about what to expect moving forward.
Okay. And I have a few more questions. How can you encourage a patient to create their own goals or find their own positive thoughts after they show resistance to these tools or respond to your prompts with, I don't know?
So there's always going to be very challenging patients. I think with our patients, we just have to be patient. And work on developing that rapport with those patients. So the motivational interviewing techniques that I discussed today is a great way to potentially facilitate that conversation when you see that patient has some resistance. It may be worth just having a conversation and saying, I've noticed that as we talk through developing goals and some of these positive thoughts, I see some resistance. Can you tell me a little bit about this? And those conversations can be challenging, but if you keep hitting that wall with the patient, I would encourage just having a conversation about it. I think we often don't communicate enough with our patients about the hurdles that we're experiencing in rehab. So talking with your patient about what you're noticing could potentially bring to light. They may not even realize that that's how they're coming across or if that's what they're doing.
Okay. And then another individual would like to know, is there further certification or credentials or formal training that athletic trainers can receive to aid in their knowledge and application of these skills in their clinical practice?
Yeah, so there's additional, of course, there's always additional coursework you can take. I would encourage athletic trainers to look on the Association for Applied Sports Psychology. There's always webinars and seminars and conferences there that can give you some additional insights and classes there that you can take through ASP to give you some additional training in these areas.
Okay. And then the final question before we turn it over to Dr. Herrera. In addition to the techniques you mentioned, are there any devices or technologies, novel or old, that you use in psychological rehabilitation?
Yeah, so I'm laughing because I see who wrote that, and I know that he knows that I love tech. So tech-driven interventions is a huge part of my research. So things like virtual reality can be used to aid in such as exposure therapy or implementing some of these relaxation therapies and techniques. Virtual reality is great because it can help to induce auditory and visual stimuli to help to enhance the relaxation experience. So virtual reality is just one, but there's a ton of other different types of tech devices. There's new devices called like a focus calm that can come out that can provide you neural feedback as you're implementing the intervention, or a device like HeartMath that can measure HRV and heart rate variability while you're completing the meditation. So there are a ton of different techs out there, tech devices available that you can use to supplement and enhance the psychological interventions.
Okay. Well, thank you so much for a great talk. Our next speaker tonight is Dr. Herrera. Dr. Herrera completed his Bachelor's of Science degree at Kalamazoo College and graduated from Michigan State University's College of Human Medicine in 2012. Dr. Herrera was named the American Psychiatric Association Substance Abuse and Mental Health Services Minority Fellowship from 2010 to 2012. He completed his residency at Michigan State University in the Department of Psychiatry. Dr. Herrera is currently the adult inpatient psychiatrist and MSU's attending supervisor for residency training at Sparrow Behavioral Health. He's also a consultant for Ingham City 55th District Specialty Mental Health Court and staff psychiatrist for Ingham County Jail. Since 2014, Dr. Herrera has been a consultant for Michigan State University's Department of Intercollegiate Athletics. Please welcome Dr. Herrera. I think you need to unmute yourself.
Sorry about that. Good evening, everyone. I'm Dr. Herrera. Nice to meet you. Fantastic lecture prior to this by Dr. Baez. Thank you very much for that. And I'm going to try and pull up my presentation here in just a minute. I have to see if somehow we can do screen. I'm told that screen sharing is made available on this. I'm trying to see how we do that.
Chris?
It should be available at the bottom of the screen. There's a green icon that says share screen, as long as you've logged in as a panelist.
That may be the problem. On my laptop, I am in as a panelist on this video, but not as a panelist on this particular link. So let me try that real quick. See if I can do that.
Okay.
And just 1 second. I also apologize ahead of time. I have a rather enthusiastic cat that often, when I've spent about the last year doing telepsychiatry, televideo from various venues, many people think I have a baby crying in the background. I assure you, it's not a baby. It's a cat who's just used to having its owner around.
Sorry, do you know what name you've logged in on for your other computer? Because I can just make you a panelist on there as well.
Oh, well, I just logged out of that. So let me see if I can do this. I will put, I had put Dr. Herrera, I'll put PP on here, PowerPoint, and see if that'll work. And now, of course, I have to verify that I'm not a robot. Open, it wants to ask me for a meeting passcode.
I can provide that.
Yeah, I think I have it right here.
I think it's just capital MSU.
Yeah. I apologize. I don't think I have ever had this many technical difficulties.
That's okay.
Let's see.
Are you ready to log in?
Yep, I believe so. Okay. Hopefully everyone can see that, and that will be the last glitch that we have. So, and can everyone hear me okay?
I think so.
Okay, good. All right. Well, apologize for the delay there. Again, my name is Dr. Herrera. I'm an assistant professor at Michigan State University Department of Psychiatry. Half my day is spent as an inpatient adult psychiatrist in the hospital, but I wear many hats, as many psychiatrists do. One of those is as a clinician in our division of sports psychiatry. And so I always like to start off with a little bit of artwork. This is artwork depicting bipolar disorder. The turbulent scene with that. So today we're going to be focusing primarily on mood and anxiety disorders. And I also included in here a little bit of discussion about personality disorders, essentially in student athletes. And so what we want to do is learn a little bit more about these disorders. I'm not going to be overly laborious in going through criteria, but we will go over it briefly. We want to think about not only achieving greater knowledge of these disorders, but also think about the types of treatments that are available. We want to gain a greater appreciation for the treatment challenges that particular patient populations, including student athletes, face in accessing mental health care. And hopefully you all will gain a better understanding of how to help these patients, answering the question, so what do I do now? What it's not meant to be, it's not intended to be a complete discussion on diagnosis or treatment. It's not meant to put the burden on you, place the burden of diagnosis or treatment on athletic staff, providers, or non-mental health practitioners. This is sort of what we do. It's not intended to label athletes as, that crazy so-and-so that sees the shrink, which I've unfortunately heard from time to time. And it's also not supposed to make you feel as if the responsibility when there is someone in crisis or in need is solely yours. So why do we care about this particular topic? Well, psychiatric complaints are common in the college population, college and also athletic settings. And then again, so are general psychosocial problems. This is an important transition and period in life, making the jump from adolescence to adulthood. And as such, many interesting situations arise. Athletic departments and sports clinics really can also provide an important setting for contextual and historical reference, which is really, really useful in the diagnosis of mental health problems. So many of the multitude of staff that work with student athletes see them day in and day out and provide us with a really valuable source of information. Mood and anxiety disorders can impact athletic and academic performance, and vice versa. And they can also co-occur with, as we heard in the last presentation, they can co-occur with and also exacerbate other problems, including recovery from injury and also substance use disorders, to name a few. And it's not uncommon because of misunderstanding, that mood and anxiety disorders can frequently be really mistaken for effort-related problems, and sometimes vice versa as well. So some of the common problems we tend to see day in and day out in a sports psychiatry setting that we hear about and also in athletic departments is people having academic difficulty, right? An athlete doesn't necessarily come in and say, hey, I have major depressive disorder, or, I have a panic disorder. We see the external manifestation of things in their everyday behaviors, and really life quality. We deal a lot with insomnia and energy issues, stress control and life balance, performance declines on and off the field. We also see issues related to injuries and return to play. Very prominent in the news in recent years has been concussion-related complications, although not always talked about in terms of mental health complications. Quite a bit of talk about neurological sequelae. We also hear a lot about anger problems, getting into trouble, adjustment to college life, and notably problems with coaches and teammates. And in my particular field, I have a subset of patients that I see for substance use disorders as well. Now, all of these tie into and in many ways impact and maybe indicators of the presence of a possible mood or anxiety disorders. And so what are we talking about in relation to those? So often when people hear words like depression, right, they think of their common experience as depression and anxiety are parts of the human experience. But really, when we think of the clinical disorders associated with mood disorders, we're talking about major depressive disorder, what used to be called dysthymia, but now persistent depressive disorder. We can see things like premenstrual dysphoric disorder, I've included a couple other things on here as well, because we do see some that are in some ways more common, some less common, but the rates of these disorders are, believe it or not, about the same in the student population, student athlete population, as they are in the general community. And those are bipolar disorder, which I'll explain a little bit why I'm mentioning that, seasonal affective disorder, very common to see things like adjustment disorders, and then also depressive disorders related to things like medical conditions, right? Concussions being one, but also injury recovery, substance use related to medications a person may be on, or other unspecified or possibly unknown conditions. As far as anxiety disorders, the ones we generally think of and see most commonly are things like generalized anxiety disorder, panic disorder, social anxiety disorder, and also manifestations of things like performance anxiety, anxiety disorders related to medical conditions, right? Injury, recovery from injury, rehabilitation, sometimes related to cardiac issues, or sometimes related to substance use, things like overuse of caffeine, use of stimulants, etc. I also mentioned at the bottom here OCD, obsessive compulsive disorder, and PTSD. While these are actually in different categories, once upon a time they were included, or at least conceptually thought of, under the umbrella of anxiety disorders, but now have their own separate classification, but we'll touch on those briefly. So in terms of how often these types of things occur, well, things like major depression in the general population, and this may even be a low estimate, 5 to 15%. Anxiety disorders, depending on which ones you're talking about, can be anywhere from 1 to 2%. Some say as high as 25% when you consider the fact that for most people, for the majority, if a person meets the criteria for one anxiety disorder, they very commonly meet the criteria for another anxiety disorder. For something like bipolar disorder, the prevalence is less, about 1 to 3% of the population. But the reason that this is very important is it's frequently underdiagnosed and has a slightly different distribution than some of these other maladies. And the fact that bipolar disorder can so often present about 80% of the time as depression. And I also made mention of one particular disorder, just because it does tend to pop up in our population, not infrequently. One way to look at this is the general topic of personality disorders in general, but in particular borderline personality disorder, which can affect up to 1 to 3% of the population. And these tend to be quite frequent utilizers of mental health resources. So they are an important consideration in our treatment population. So just to read through a quick case example, sort of give a sense of what one of my days is like, but may in many ways mirror a particular student athlete that may come to you. So in this example, Sarah is a 19-year-old freshman collegiate athlete who recently admitted to her trainer after breaking down at practice that for about 10 days or so, she's been depressed, had suicidal thoughts. Recently moved from another state to attend college and to try something new. Reports a history of previous psychiatric treatment since the age of 15, with one previous psychiatric hospitalization for overdose that happened with an antidepressant. Up until this time, treatments consisted primarily of medication, including antidepressants, sleep medications, and at some point in the remote past, a stimulant for ADHD. She mentions that she can't afford therapy and really doesn't like talking about her problems anyway, because they really don't matter. Upon meeting with the sports psychiatrist, she reluctantly reports a history of superficial cutting in high school. The last engaged in this about 5 days ago when things were really tough, along with persistent, although waxing and waning, thoughts of death. Notes chronic depressed mood, and even mentions frequent mania, consisting of 1 to 2 days of increased energy, sleep deprivation, irritability, followed by sleeping a ton the following day. many times admittedly after an alcohol binge. While the psychiatrist is speaking with her, she appears generally downtrodden, but otherwise seems generally intact overall. She really describes nothing working to treating her depression, which she goes on to say is often prompted by difficult interactions with family, boyfriends, more recently teammates and coaching staff who treat her awful, although she describes outside of this having lots of really close friends. During the history, she alludes to a history of numerous past traumas that she didn't really want to talk about. She reports her mood all over the place and comments to the provider, this is all confidential, isn't it? You're not going to tell the coach any of this, are you? So what are the challenges in treating student athletes for mood, anxiety disorders, and the like? Well, if you think about the many things, not just that are on student athletes' plates, but also the experience of being a sports athlete, right? For many people, they say, you're a scholarship athlete. What do you have to be worried or sad about? You got a, free ride to college. And other comments can be, everyone's so proud of you. You're really in an elite, rare group. This can bring about feelings of needing to be perfect or not wanting to perhaps talk about one's problems, guilt for feeling not well. In the culture of sports, there can be, at times a notion of, hey, just got to get through it. No room for weakness here, especially as the level of play and competition goes up. And then, of course, from the athlete's perspective, athletes want to play. They want to be on the field. And so we face the challenge of, just as it may occur in injury treatment, it can also occur in mental health treatment, where the person may not want to portray impairment because they feel that it might threaten a very important part of their existence. When we think about anxiety disorders, right, here's a general overview of a few. Generalized anxiety disorder, which we kind of think about as the people that are the warriors, the worry warts. Panic disorder, some people talking about, I get freaked out, I get panic attacks. Social anxiety, which may appear as a person saying, I don't need to go out, or if I do, I usually need to get high or drunk to do so. Again, I made mention of OCD and also obsessive compulsive personality disorder, which have some similarities to one another. Also PTSD, someone who's been traumatized. And then the frequent comment, which it should at least lead us to think about anxiety disorders, is when a student athlete comes in and has complaints of, I can't concentrate, right? The ADHD, as it were, referral. The important thing to take home from this is that in many ways, again, a student athlete may not come in listing criteria, but other people, trainers, coaches, family members, teachers, mentors, other students, teammates, may notice that they're just not acting like themselves. They just seem to be struggling. And it's important to have methods of screening and asking, as again, our previous lecturer mentioned, in an empathetic way if you have concerns about how someone is doing, because they may not come forward and talk about it. When we think about generalized anxiety disorder, we're really talking about excessive anxiety or worry of 6 months or duration or more. Many times, but not all, people will have a history of being described as difficult to soothe or a worry growing up, but it doesn't always have to be that way. This can occur at any time, and really tends to be associated with at least 3 of these criteria: feeling restless, heat up, but also sometimes an athlete may complain of fatigue or difficulty concentrating, irritability, muscle tension, or sleep problems. They may not come off as someone who is just a very fretful, worried person. But one can never know what's going on in the inside unless one asks about it. And it's a good time to add that really all of the anxiety disorders is defined, because there can be crossover. There can be generalized anxiety disorder with panic attacks. There can be PTSD or social anxiety with panic attacks. When these disorders are named as such, they're really focused around the central core problem. So in the instance of panic attacks or panic disorder, this really has to do with the recurrent unexpected panic attacks, right? Can feel like they're having a heart attack, actually, and frequently is accompanied by things like persistent worry about having panic attacks or the consequences of having another panic attack. And these can lead to what we think of as maladaptive behavior, so avoidance of things, right? Not leaving one's room, not wanting to go somewhere where they might have a panic attack and be embarrassed, what have you. It's important to remember that we always think about the possible medical causes that could cause these phenomena as well. So we want to be careful to rule out that it's not due to any medical condition or a substance that the person may be using, because those are important sources of this type of experience as well, but don't tend to totally fit the bill of what's been described. For social anxiety disorder, this really has to do with a marked fear or anxiety about one or more social situations in which a person may be subject to scrutiny. And one might say, well, these are athletes, they've been performing in front of people for, probably as long as they've been playing the sport. And they may well have adapted to that. A lot of times the person can get through the situation, but with great distress. Many of you may know this, but there was a famous running back a few years ago that famously suffered from social anxiety disorder. In fact, he always wore sunglasses, smoked a ton of weed, even wore a visor on the football field, and very, very much had difficulty looking people in the eye, despite the fact that he was a high-level NFL athlete. Very notably struggled for a long time with social anxiety disorder. And this is something that really is associated with fear that the person will act in a way or show anxiety symptoms that are going to be negatively evaluated. This kind of social situations almost always provoke fear or anxiety, and they tend to be avoided or endured with intense fear or anxiety related to it. It's important to note that the fear most often is out of proportion to the actual threat of any type of embarrassment, right? I might say something stupid. Well, that's possible, but is the degree to which you're avoiding this really realistic to the likelihood of that or the consequences of that happening? It tends to be persistent and importantly causes clinically significant distress or impairment in either social, occupational, or other important areas of functioning. This is not sort of just being shy. This is really, it gets in the way of accomplishing what someone wants to. And this is an example, as our last speaker talked about, of really using the person's words, right? How does it impact them? Not how we perceive it, but how do they feel like it's impacting them? Because so many people ask me about obsessive compulsive disorder, really, this is the presence of obsessions, compulsions, or both. So obsessions are recurrent or persistent thoughts, urges, images that are experienced as intrusive or unwanted. Really, the person tries to ignore or suppress these or to neutralize them with some other thought of action, for instance, a compulsion, which tends to be repetitive behaviors or mental acts that the person feels driven to perform in response to the obsessional thought. These are generally aimed at reducing the anxiety or distress that they feel, preventing some dreaded event or situation. But importantly, they're not typically connected in a realistic way to what they're designed to address or neutralize. So you've all heard of people washing their hands obsessively, checking, locks frequent times, etc. Outside the norm of what might be reasonable behavior. In talking about one of the most misunderstood topics, that of depression, right? The common response to depression is, well, I get depressed too. And it's true. People have times when they are down about various life events. We even have, when it's clinically significant, a term for that type of impairment. We listed under what's called an adjustment disorder, sometimes with depressed mood. But really, major depressive disorder consists of a constellation of symptoms that have been present for at least the same 2-week period, and really importantly represent a change from a person's previous functioning. Now, one of the symptoms has to be at least depressed mood or loss of interest. Loss of interest or pleasure. Now, it's worth mentioning as well that this is something that can also be objectively observed by others. It's very, very important when you take into consideration the fact that a person may be reluctant or even in some ways unaware that they may be suffering from a depressive episode or profound depression, that other people notice that they don't tend to be doing well. And that's where all of our colleagues, all the people that work with student athletes become very, very important. If you see a change in someone's behavior, it's worth asking about because they may not offer this up. And this is not just a case of the blues. Really, when you look at what would qualify as a major depressive episode, we're really talking about a depressed mood, right? Sometimes can present as irritability as well. Most of the day, nearly every day, again, by subjective report, someone saying they feel sad or empty, but also by observation of others, appearing withdrawn, tearful, etc. There has to be markedly diminished interest and pleasure. We call this anhedonia, right? In all or almost all activities of the day, nearly every day. Okay, you may see significant weight loss, or when not dieting, or even weight gain. One of the benchmarks is a change in more than 5% of body weight in a month, or a decrease or increase in their appetite nearly every day. So this may be seen in somebody who's not gaining in the weight room, for instance, even though they're putting in the work. You can see almost universally in mood disorders some type of sleep disruption, usually insomnia, but sometimes hypersomnia, sleeping too much. And this can be an important red flag or clinical indicator of different types of what we call atypical depression. You can sometimes see what we call psychomotor agitation or retardation, moving more slowly, not just feelings of restlessness or being slowed down, but observable by others. They're fidgety, or they seem much slower than you're used to seeing them. A lot of times they can complain about fatigue or loss of energy nearly every day, and you can easily see how this might be masked in all the other toils of the day in the busy schedule of a student athlete. A lot of them are fatigued and feel like they might not have energy at times that you may see them. Pathological guilt, feelings of worthlessness or excessive or inappropriate guilt, which may even be sometimes delusional. For instance, feeling like guilt that they never should have been born. This isn't merely self-reproach or guilt about feeling down. This is really more profound than that. A person who's suffering from depression may talk about diminished ability to think or concentrate, or it may come out as indecisiveness really every other day, or and it doesn't have to be every day. It can come and go to an extent. So we always think about this when we have people that come in and say, hey, I can't concentrate in class, et cetera, et cetera. We always have it on our differential. Importantly, recurrent thoughts of death, not just fear of dying, but things like recurrent suicidal thoughts, with or without a specific plan, or suicide attempts, or even vocalization of a plan. It's important to also note that the symptoms should not be due to the direct physiological effects of a substance. So we have to screen for things like drugs of abuse or medications or general medical conditions, like, for instance, hypothyroidism. And the symptoms have to cause clinically significant distress or impairment in one or more areas of their life. Now, the topic comes up from time to time about the notion of bipolar disorder, or what we used to call manic depression. It's not uncommon that people will false positively screen for symptoms of mania, right? Just to give you an overview, manic episodes are really distinct periods of abnormally and persistently elevated, expansive, or irritable moods with persistently increased goal-directed activity or energy. This was one of the newer criteria that was added. Has to last for at least 1 week, and usually accompanied, not always, but usually, by some type of profound sleep disruption. Now, we don't typically tend to see this in the settings that we work in, or associate with student athletes. And more often, one might see symptoms of a hypomanic episode, which are really all the symptoms of a manic episode, but less severe and less time duration. Again, all the mood symptoms. The key here is that a hypomanic mood, elevation, euphoria, irritability, is really supposed to be clearly different from the person's usual mood. This is unusual. It's not somebody elated. When you think about all the emotions involved in athletic participation, this is things like quickly changing, even within the course of a game or competition or what have you. Elation, anger, frustration, sadness. This is not the sort of mood lability or quickly changing moods. This is much more of a sustained phenomenon that people who know the person, and this is why people like trainers and family and teammates and coaches and everyone else are so vitally important, particularly for the sports psychiatrists and sports psychologists, because a lot of times we don't know these people and we don't know what they're like normally. So during these periods, person may have things like inflated self-esteem or grandiosity, right? Decreased need for sleep, more talkative than usual, pressure to keep talking, ideas that seem to be run-on sentences almost, or a subjective feeling of their thoughts are accelerated, highly distractible, right? Increase in goal-directed activities, socially, work, school, sexually, or psychomotor agitation. Also, excessive involvement in activities that have a high potential for painful consequences, right? Going on spending sprees, sexual indiscretion, foolish sort of spending or business investments, making decisions that don't seem to make sense. Again, this is a change in functioning that is uncharacteristic, right? And in some ways, in that way, can fly under the radar. But again, this is not supposed to be subtle. It's supposed to be directly noticeable by others. Now, the critical thing about hypomanic episodes is usually it's not severe enough to cause severe impairment. Okay, they still may function on a very high level, but it definitely brings attention to their conduct. And typically we don't tend to see any psychotic features. Now, this has to be, again, not due to any medical illness, alcohol, drugs, medications, etc. Why do I mention hypomanic episodes? Well, they can be fleeting, but it's important to know that bipolar disorder, which is a very difficult diagnosis to make, can so often be incorporated into the experience of people with depression, right? About 10 to 15% of unipolar or major depressive disorder will be revised to bipolar disorder, although some studies suggest as many as 30% meeting criteria. The reason so much of this is important is that 80 to 85% of the time, bipolar disorder may present as depression, especially bipolar 2 disorder, which tends to see hypomania, but not mania itself. And treatment is very different, right? As is the presentation. Really, unipolar major depression tends to be a disorder of, starting around age 40 or so. Bipolar depression, we think, tends to occur earlier on in onset, which makes it important for a young student athlete population, and is notably can be more difficult to manage, right? The depressive episodes tend to be a much more acute, rapid onset, split equally between females and males, and much more unstable in the case of bipolar disorder, where people tend to experience more mood episodes. There may also be some atypical symptoms. I won't go too much into this, but we do look for more of vegetative or atypical symptoms when we think about a diagnosis of bipolar disorder. And it's also important that when we treat someone for suspected depression, that we have a monitoring system, because the treatments can be very different. Antidepressants are typically, when indicated, the treatment of choice along with psychotherapy in unipolar depression, but can actually destabilize somebody with bipolar depression. So if someone, particularly in a young age group, is not responding well, we have to think about looking a little bit deeper into the situation, as well as things like a family history, which tends to be more common in bipolar disorder. And so this is a quick illustration from my world in the inpatient unit. This is an example of a person suffering a bipolar manic episode, right? And you can see the abundancy of writing in here, right? This is very colorful, very flowing of ideas. I think that this person completed all these papers in about, say maybe like 15 minutes, and insisted on putting them all up on their door. Briefly, we'll talk about personality disorders, just because so often there is a co-occurrence with mood and anxiety disorders. And frequently, many of the problems that come up amongst the student athletes, we at least have to have this on our radar. A personality disorder is really a way of thinking and feeling about oneself and others that significantly and adversely affects how an individual functions in many aspects of their life. Now, there are quite a few of these. I highlighted borderline personality disorder and obsessive compulsive personality disorder because these are probably the two that we see most often and are important in differentiating amongst the other problems that we see. Really, personality disorders affect things like the way that a person perceives or interprets themselves, other people, events. It can affect things like their range, intensity, and the appropriateness of their emotional response. It can impact things like the way that they interact with other people, and also things like impulse control. Personality disorders tend to be inflexible and pervasive across a broad range of situations. So, this person may talk to the orthopedic surgeon the same as they might talk to their friends. when there's not maybe a context to do so, or to their teacher, and the same as they might a parent. You might see something like that, just sort of has a loose style, if you will. These tend to be stable and of long duration, and the onset is usually traced back to at least adolescence, if not early adulthood, and is not typically better explained as manifestations of other mental or medical disorders. Now, how often do these occur? Well, between 30 and 70% of depressed patients can receive a concurrent diagnosis of personality disorders, at least in my world, in the inpatient setting. Usually these are of cluster B, of which borderline personality disorder will be included. But importantly, personality disorders very much are people that are suffering. These people oftentimes will meet criteria for some type of mood or anxiety disorder sometime in their lifetime, with some estimates in the 30%, but also anxiety disorders, eating disorders, substance use disorders, and the like. Very quickly, when we think about the notion of borderline personality disorder, and you can sort of think about whether or not this fits any person you've worked with in the past, or these a lot of times tend to be athletes that seem to bring about chaos and drama in their individual lives, or importantly in a team setting. Really, borderline personality disorder is about a pervasive pattern of instability of interpersonal relationships, self-image, and affects or emotional regulation. Okay. As one saying goes, they love without measure, those they will soon hate without reason. Okay. In borderline personality disorder, we tend to see things like marked impulsivity, okay, which can be present in a variety of contexts, indicated by 5 or more of the following. So these can be people that make frantic efforts to avoid real or imagined abandonment. Right? Get really, really disrupted when relationships dissolve, and can go to great ends to try to rescue them. They tend to have a pattern of unstable and intense interpersonal relationships that really oscillate between extremes of idealization and devaluation. We sort of call it the angel and the devil phenomenon, if you will. There can oftentimes be things like identity disturbance, having a persistently unstable self-image or sense of self, often sort of not knowing who they are, feeling empty at times. Now, we all have to take into context the fact that the population we work with is very young, and life is a journey, and they are still finding themselves. It's not to be mistaken for a personality disorder per se. The impulsivity can be seen in at least 2 areas that are potentially self-damaging. So we not infrequently see people engage in reckless and dangerous substance abuse, binge eating, reckless driving, etc. You can see recurrent suicidal behavior, gestures, threats, self-mutilating behavior such as cutting and burning, affective instability due to a marked reactivity of mood, right? This is the sort of intense episodic irritability, anxiety. The difference being, if you think back to bipolar disorder, tends to only last a few hours and rarely more than a few days, and many times is prompted by external events. So you can see a person also complain of things like chronic feelings of emptiness, displaying inappropriate, intense anger, or difficulty controlling anger. You can even see things like transient stress and related paranoid thoughts or dissociative symptoms. So in our overview of these disorders, how do we move on to treatment? And there was some really nice commentary and instruction on the different modalities of treatment in the last segment. So I won't go into this extensively, but in general, for mood disorders, say for instance, depression. For mild to moderate cases, we tend to think of, and the studies pan out, that psychotherapy can be as effective as medication, with maybe some minor weight in favor of combined treatment, adding both of these. But by and large, for mild to moderate, really could start with either. For moderate to severe depression, we tend to do best, the person tends to do best with a combination of medication and therapy, for a duration usually anywhere from 3 to 6 to 12 months for a first episode. For things like seasonal affective disorder, we find things like light phototherapy 2 to 3 times a week for about 20 minutes. And we have a few of these in our athletic training area, for students to come by and sit under the lamp and study, or what have you. This is found to be very effective. And essentially a very similar approach for anxiety disorders as well. There are some specific types of treatments for things like anxiety and depression, the most evidence-based one being cognitive behavior therapy, which was touched on in the last segment. But of course, there are some exceptions for other disorders. OCD, as an example, being responsive to exposure and response prevention and systematic desensitization. For borderline personality disorder, we generally recommend dialectical behavior therapy. And for social anxiety, many forms similar of exposure therapy can also be helpful. And this can be extended to other areas, as also was mentioned, for rehabilitation, when there's felt like, you've got a student athlete that's struggling in terms of doing their rehab. We have to think about these things and how we can incorporate some psychotherapeutic techniques, which may not necessarily always be thought of being included in things like physical therapy, and general injury rehabilitation as being relevant. In terms of medication, many of you may be familiar with these from one avenue or another. We generally tend to, when we choose a medication, to think about the class of medications called SSRIs. These are medications like Prozac, Zoloft, Paxil, Celexa, Lexapro, each with some of their own FDA indications, but by and large, most are about the same in terms of efficacy. There are not real great head-to-head studies, and the ones that are done tend to say that most of them work, decent enough, not really one better than the other. We tend to choose based on different nuances, for instance, the level of activation that they may have. They tend to be much safer in things like overdose, right, compared to some of the older medications like MAOIs and tricyclic antidepressants. And really for certain conditions, amongst those being anxiety disorders, obsessive compulsive disorder, we even find that we have to use super therapeutic doses above the listed maximums to really get full benefit. Sometimes the same for refractory illness. As I mentioned, they're generally very well tolerated, but it is important to ask about things like if a athlete has been started on a medication and they're complaining of not being hungry, or stomach upset, diarrhea, constipation, headaches. Those are important things to help them tie to perhaps speaking with their provider. I highlighted sexual side effects because these can be very common as well in these medications, and by and large, both in general population studies and also our more specific populations, they're not side effects that people tend to bring up, but they are a frequent reason for stopping even a effective medication. So it's important that we ask about those things because someone may be reluctant to bring them up. Now, because we are talking about an age group that there still is a black box warning in adults and children under the age of 25 for increased suicidal ideation, this is where the setting of frequent contact in an athletic department and working with athletes is important. A person should feel better, not worse. And so, although generally, we think these are very safe medications. And in fact, at one time when this black box warning came out, prescribers, mostly in the primary care field, stopped prescribing them over fear of suicidal ideation. And for the first time since the advent of Prozac, the suicide rate went up, not down. And when these were reinitiated, the suicide rates started to drop again. But it is important to ask about this. Another class of medications, SNRIs, just have an additional neuromolecular neurotransmitter aspect to them. These are medications like Effexor, Pristiq, Cymbalta, etc. One of the important indications or usefulness of this is actually in pain management. Right? They have one of these in particular, Cymbalta, has an FDA indication for monotherapy, including in comorbid pain treatment. So just treating pain alone. And the mechanism is fully elucidated in this, but we think that these can offer an important adjunctive role in helping athletes who are in pain. We do have to watch for things like elevations in blood pressure and heart rate, and they are a little bit more difficult to stop and start compared to SSRIs. Some of the hybrids and outliers that we use, these niche drugs, are things like Wellbutrin, better for those vegetative symptoms that I mentioned before. Sometimes we use them to treat sexual side effects of SSRIs. Sometimes we use them to help people decrease their use of nicotine. We try to avoid them in things like people who have high anxiety, who have a history of seizure disorders or eating disorders. Some of our other useful agents are medications like Remeron, which we use for people that are having in particular sleep and appetite problems. Buspirone, which is a medication that's used primarily mostly for anxiety, but for people who are a little bit reluctant about medications, very well tolerated as well. When we think about treating insomnia, two of our primary classifications are things like trazodone and the Z drugs, Zolpidem or Ambien, and Zleplan or Sonata. Now, some of these medications, including things like Wellbutrin, can trigger false positive drug tests. And that's something we always keep in mind as well, particularly for amphetamines. Most of you are probably familiar from airline travel, traveling across the country for athletic competition, of things like melatonin for treating jet lag. We also use other medications, even as simple as Benadryl, for helping with sleep. And there's some newer agents that also are out that we sometimes utilize as well. I mentioned Ambien and Lunesta previously. These are medications that have, if some of you are familiar with medications like Xanax or Ativan, these have benzodiazepine-like properties, but they really have more of a sedative effect, and we don't tend to worry as much about respiratory depression, but they can cause some degree of hangover, amnesia, and you've heard probably about sleepwalking and sleep driving. So we use them with some limits and reservation. As I mentioned, most of you are familiar probably with handing out melatonin supplements on the flights to when there's a significant time shift. I won't go over that much, but the one thing to keep in mind is that the athletes that utilize it sometimes take too much, which can have the reverse effect when people are popping 4 or 5 milligram melatonins and complaining that their sleep is not any better and may in fact be worse. That can sometimes be a cause. So we're coming to the end of this. When we think about questions of where does care take place, and to borrow from one of the good manuals, the textbooks on sports psychiatry programs, there's a term for this, these team assistance programs. Ideally, we want to locate these at or near the training room or athletic facility. And at MSU, we often see our consultations and student athletes in this setting. Obviously there are some concerns about things like confidentiality boundaries that have to be considered, but many times being able to communicate with the other athletic staff is very, very important. And tends to work out well coming to the person as opposed to being offsite or off campus. That tends to work a little bit less well for us, at least. And when setting up one of these programs, you want to think about obviously these issues, right? Design, but also the budget, confidentiality, and interestingly, who's being served in this? Is it the athlete that's being served? Is it some other entity or person that we're really addressing some of these issues? And then we always have to consider emergency issues, right? One of the biggest being suicidality, what to do in those cases. And it's a question that I get frequently and was asked to comment on for this presentation. It's a difficult question in some ways to answer. In so many ways, it varies by state mental health code laws, depends on your location, what entity you're at, right? Whether it's a physician's office, an orthopedic office where an athlete mentions suicidality, depends on your staffing and the design of your team assistance program. Here at MSU, we have some degree of crisis screening, but it's not uncommon for us if a situation is unclear, and I often get phone calls about this, to take someone, like any other emergency. And let's be clear, things like acute suicidality are a medical crisis. Just like if somebody's having chest pain, like if somebody's collapsed for some reason, they need to be evaluated on an emergency basis, not just sort of cast away to follow up at the counseling center the next day. How do you go about this? Well, there's a couple different ways, and again, it varies by state and location. There is what's called a formal voluntary admission process. A person can agree to seek help, and many times this has to do with inpatient-based care, but it doesn't always have to. There are the presence of partial hospitalization programs, which are day programs. There are residential programs. There are crisis-based programs as well. But if a patient meets the criteria for acute inpatient admission, which is usually predicated on imminent safety, are they at risk of hurting themselves in the near future or someone else, or are they so profoundly impacted that they're not taking care of themselves, they may be eligible for admission to the hospital. Now, generally, this is something they'll take care of either in a psychiatric care clinic, but it can be in any medical clinic, including primary care. Probably not something that athletic trainers or athletic staff are going to take care of. But there is the process of involuntary hospitalization, either by what's called an application, or in the case where the court is actually petitioned to issue a pickup order, right? You have an athlete that's not coming out of their room talking about suicide. Sometimes the court has to order a police pickup of the person to be evaluated. But if you are privy to information where someone has been threatening suicide, you may be asked to fill out, either in an ER setting or some other setting, what's called an involuntary application, where you simply state the facts and your reason for concern. This can be an important step because so many of you have firsthand experience with the athlete. In the end, really the rule is safety first. We take the mention of suicidality, suicidal thoughts, or any potential homicidal or aggression towards anyone else, or things that you can't always go, just the hair on the back of your neck is standing up, but particularly suicidality, we take it very seriously and we communicate as such. And I think as was mentioned on another topic, so much of it is about what you set up ahead of time. You never want to practice a fire drill in the middle of a fire. So you want to have a fire safety plan ahead of time and practice it and think about and even do some degree of psychoeducation with people that, if they're struggling and you're worried about them and they mention, that they may be hurting themselves or people are worried about them, it's time to get an evaluation. And typically that's taken care of in an emergency setting. So that's very, very important. Some useful tools to learn more. I really recommend National Alliance on Mental Illness. In Michigan, you can look up namimi.org, or you can just put in your favorite search engine, National Alliance on Mental Illness, and it's divided by state chapters. Very helpful to learn more about networking, education, and support for people who either individually suffer from mental health problems or who are trying to help someone. A lot of good tips and ways to support them, including support groups that they can join. And then I also, if you want to learn a little bit more about borderline personality disorder, there's a good website there as well, the BPD Resource Center, that talks a lot about diagnosis and some of the etiological aspects of borderline personality disorder and how this develops. I'll leave you with a quote from Terry Cheney, indeed the daughter of Vice President Dick Cheney, who famously suffered from bipolar disorder and wrote a book called Manic, a Memoir. And in it, she writes, "Perilous highs and desperate lows and extravagant flurries of mood are not always symptoms of a broken mind, but signs of a beating heart." Thank you very much, and I will take any questions that you might have.
Well, thank you, Dr. Hura. That was a fantastic talk. I have quite a few questions of individuals who have sent me some of their questions via text message. My first question is, what is the biggest tool that an athletic trainer can use when faced with a student athlete having issues and a mental health specialist is not available?
I think the question is probably not going to be surprising. Depends on some degree of perspective and judgment call on the part of the trainer. So if there's any whiff of safety, I do not think it's a bad idea to think safety first. And I was just having a conversation with someone the other day, really mentioning to them that you're worried about them. So often trainers and coaches, athletic staff have relationships with athletes that have been formed over time, and even with the ones that they haven't fully formed this, know that they have their best interests in mind. And talking about, for instance, sometimes people are mandated reporters in instances of safety. Sometimes depersonalizing, saying, we need to go and see if we can get you some help is the best route to go. Now, how that actually takes place depends a lot on the organizational structure of where you're working at, right? There may be a counseling center. Ours has a crisis services, like a walk-in clinic. But when in doubt, much like somebody grips their chest with chest pain and you're not sure, but they don't look good and you don't feel good about it, hey, there's nothing wrong with taking them in for an evaluation. They may not admit them. The person may be a little miffed about it, but I think if you communicate that you're doing this out of genuine concern for them, that you take them seriously because they're talking to you for a reason. When I first got into inpatient care, it used to be the notion that we never really saw the people that were suicidal because they already committed suicide. We never saw them in the hospital. They would get picked up by the EMS or the police, oftentimes without a previous mental health history. And so we take some stock in the fact that somebody's actually able to talk about it. And I think if you create an open environment, a respectful and genuine environment for them to talk, many times there'll be they may not like it, but they'll respect you for, for listening to their concerns and really saying, I think as was mentioned in the previous talk, that this is out of the scope of my expertise. I'm not sure what to do here, but I wonder if we could go and get some help about, maybe how to help you, to help you work through this, and whether or not, how we can work through that.
Okay. If we have an athlete who is cutting and that individual is seeing a psychiatrist, what is the role of the athletic trainer? Should the athletic trainer be checking to see if the athlete is cutting?
My shorter answer would probably be to say no. It depends, of course, on in part, and this is why I talked about a collaborative approach, right? That ideally the sports psychiatrist should be centered in and located, and the services should be provided for these treatment assistant teams in the settings that athletes are seen. So there can be some of these discussions, but by and large, if the psychiatrist is aware of that, if they're worth their salt, they're going to, I think, work out some type of contingency plan for what does that mean, right? And although I would say that if somebody comes in, bleeding from their arms, very obviously in front of a trainer, they're probably trying to say something, right? But many people cut in areas that you can't see, and so I think the process of in essence, what would equate to like a strip search or something, looking for that. I don't think it's necessarily advisable. They should be following the contingency plan set up with their provider. It may be very embarrassing for them to go through that type of surveillance, if you will, and to some degree, one might even say it may be playing a bit into some of the inherent pathology that may be present. I say may, but may be present in individuals who self-injure, and reinforcing of aspects that we do not want to reinforce. I get this often too with athletes that publish on social media, right? And they make it available for everyone to see, and they talk about suicidal thoughts, and someone's reading a blog, and then the next thing you know, somebody's texting or calling someone saying, hey, so-and-so's talking about suicide. That's something that really, needs to be worked out in terms of the downstream consequences of that behavior and contingency management for that type of thing. But I don't think going searching for it is necessarily the answer. I think, if anything, a communication about, if the athlete is open to that, of what that means. Hey, we need to know when you're struggling, because we're here to help you. And I'm not I say this all the time as a psychiatrist, I'm not a mind reader. You can be in pain, but you shouldn't have to suffer alone. And, we'd appreciate it if we knew beyond having to see it displayed, if you will.
Okay. I have another question. I understand anyone can fall into depression for a variety of reasons at any time. But for other disorders you spoke on, what is the likelihood that they would get those disorders while they are a college student athlete? Or did they likely have it and it wasn't picked up on, or it was missed?
The simple answer is that these can develop at any time. So I'll use the example of generalized anxiety disorder. One of the frequent things we ask about is, have you always been a little bit of a worrier? A worry where since growing up, did your parents have to reassure you, or friends or family, about things that didn't even seem like were that worrisome? When we latch too much on that conception, we forget the fact that these things can develop at any time. And so, one of the things in medical school was the patients don't read the textbook. It sort of is what it is. Um, this is, again, an important transition of an important time period in their lives. They are, some of them are away from home for the first time. There's an enormous pressure at this level. There's enormous juggling that has to go on, all while making this transition from being an adolescent to an adult. And, in the field of mental health, we often say that in particular, that period is a very very important period to monitor for the development of some of these problems, particularly because when you think about where their life has been spent prior to that, from so many of these, it's in a very structured environment. Home. It doesn't mean it was great or not chaotic or any of that. It just means that for the first time, so many have freedom, and that can lead to a lot of things. I don't know if that completely answers the question, but I think you just really have to be on guard for anything. And in the end, we don't expect people to be diagnosticians. Probably the greatest tool, much like when I have family meetings on an inpatient unit, that one of the first things I say to them is, this person. I say it to the patient because they want to be the owner and the agent of their experience, but also to the family. This person. We see them come in at their worst, so we need to know where we're trying to get them back to. How much do they seem more like themselves? And so for those of you that know these athletes well, that's an invaluable resource to be able to give that perspective, particularly to the sports psychiatrist, because you tend to know many of them well.
Okay, I want to point one thing out, and then I'm going to continue to ask questions for those who would like to stay on. If you go to the chat, you can see that there is a link to the survey to complete the evaluation, and you need to complete the evaluation in order for you to get your CEU certificate. And Chris is also going to send out a reminder email tomorrow in terms of that. So those of you who need to go can go, but I do have some questions that while you're on, we like to see if we could ask you a couple more questions.
Sure.
What is the approach if a patient abuses substances that impact their mental health, but are adamant that nothing is wrong or deny that they're negatively affected?
Mm. Oh, if I had a dime. And I
know you are a drug and alcohol counselor at MSU. So what do you think about that one?
If I had a dime, it is a challenge. Well, first of all, every school, every athletic program should, and I believe has to have some type of policy regarding this for intercollegiate participation. The use of substances can negatively impact not only health, but academic and sports performance, whether a person believes they do or not. And so often the people that come to me come to either by way of a positive drug test, screening drug test. So there has to be a robust program based on the philosophy of the program and whatever policy they have in place and enforcing that, but also sometimes based on suspicion. And when you've done enough work in substance use counseling, I always use the frame of reference of like court-ordered counseling. It doesn't go over very well, being told what to do. People really don't like to be told what to do all that much when it comes to negative aspects of their life if they can't see the immediate return of investment. And so much of substance use treatment has to do with where they're at in their perspective of things. And I think Dr. Baez, our last speaker, spoke very nicely about motivational interviewing, which is a, a great resource and tool and approach for really attempting to bridge the gap between insight that there may be a problem and it has a good evidence base in treatment of substance use disorders. This is my personal approach. And I'll just use the example when they have a positive drug test, as it were. We do some of our talk about that, right? But what I try to think about is their overall experience, not just considering whether or not there may be aspects of mood, anxiety, or other disorders, right? Not just considering that they're a college student who wants to experience life, but what are their goals? Starting with their goals, how they see things. And I find that if you can align, particularly on, the concrete aspects of what substance use means and how it can be impacting things. For instance, it can threaten someone's scholarship or participation. It can have the coach saying, "Hey, I'm not cool with this." We have a lot of discussion about, the moral aspects of substance use versus like the practical aspects of things, that people do things for a reason, right? But as they grow into an adult, it's about making good choices that are compatible with the many situations in which you may have to choose one thing over another. And for them, that may be choosing athletic participation over chronic weed use, right? Or alcohol use or what have you. But I think when you can understand and listen to what it is that's important to them, and not just because so often the notion of substance use comes with, "Hey, you're just doing something bad." And the immediate pushback is defensiveness, right? I think when you can take a more open mind to it, not, saying it's okay, but rather listening to them, I found that many times we can find some alignment in what they do want, and then provide some type of education of how to get there. And a lot of that's through motivational interviewing. What would it mean to not be using this substance anymore? Yeah, things like that. How might it aid you?
What should we tell a coach if we send the athlete to a psychiatrist, but the athlete doesn't want us to say anything to the coach? However, we think the coach's behavior is adding to the athlete's issues.
It's a good question. This goes back to talking about structure, right? Structure of the program and who the treatment and assessment program is really designed to help. When I first got into the world of sports psychiatry, the joke was sort of like we treat the coach by treating the athlete, because so often we would get these referrals of something's wrong with this person, or I just don't like what's going on with them, and that would be the trying to fix that particular problem. But confidentiality is confidentiality between the trainer and the athlete. If that arrangement was made, right, we're going to have you go see a psychiatrist, and the athlete doesn't want the coach to know. The fact that the trainer knows that the trainer is in a difficult situation, right? They're sort of caught in the middle in some ways. But having a conversation, and again, asking the athlete, "Hey, sometimes coach is pretty rough on you. Do you think that has anything to do with the way that you're feeling? And do you think that would be helpful information?" Now, the athlete can pass that on to their psychiatrist. But a psychiatrist, it's not infrequent that we receive information, right? Particularly if someone is knowledgeable that they're they're being seen. If we got a referral from a trainer for an athlete, we frequently communicate with the trainer. And it's a delicate balance, right? You want to maintain the confidentiality and the ability for the athlete to truly open up, but also recognize that there's going to be interested parties in what's going on behind closed doors, how that's impacting things. And so I think there's some methods of communication that can be worked out to pass on that information, either through the athlete or through communication with the trainer, especially if they made a referral.
Okay. Well, I'd just like to thank our two speakers tonight, Dr. Bias and Dr. Herrera, for a great presentation. And again, tomorrow you will all be receiving an email to get your CEU certificate. So if you fill out the evaluation, it'll have information there for us to be able to send you the CEU certificate. I hope everyone has a great night. And thank you again to our speakers. Thank
you very much. It was a pleasure. Very broad subject, and we appreciate the chance to speak with you all. Thank you all for the work that you do.
Thank you.
All right.